Hello, everyone, and welcome to the InTouch Health Webinar Series. This is Scott Young, and I'll be your host for this webinar. Today, we will be featuring John Mackenzie as he leads us through the Dignity Health Telemedicine Network's decade of operations that continue to support one of the largest nonprofit hospital-based telebehavioral health platforms in the nation. Today's webinar is brought to you by InTouch Health, the platform which will virtualize healthcare from the inside of the health system out. John has worked as a psychiatric nurse, supervisor, and interim inpatient director for mental health services, focusing on patients' rights, mental health parity, and modernizing mental health law. John is active with the California chapter of the American Psychiatric Nurses Association, the Behavioral Health Division of the California Hospital Association, and served on the Solano County Mental Health Advisory Board. John is a retired member of the United States Air Force Reserve and continues to focus on creating full mental health parity on par with traditional medicine. John has been the RN coordinator of the Dignity Health Telemedicine Network's behavioral health service line since 2015. Currently pursuing an advanced degree as a nurse practitioner and doctorate of nursing practice, John hopes to create mental health clinical practice guidelines equal to that expected of STMI, stroke, and sepsis. We will begin our webinar shortly, but first, a few notices. You have all been auto-muted, but if not, please make sure to mute yourself. During the webinar, you'll be able to enter questions in the questions widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent to registrants. This webinar presentation should last around 60 minutes, including time for questions and answers. And now, I'd like to turn it over to John.
Thank you, Scott. I just wanted to say thank you to Scott, to InTouch Health, to Yulin, Wang, and everybody at InTouch for enabling us to participate in this webinar series. We're hoping that we can get the rest of our clinical team on to discuss some of the other services that we offer. But first, I'd like to just go over who we are, what the Dignity Health Telemedicine Network is, and then we'll get right into some of our experiences. And honestly, just I welcome everybody's questions, and hopefully we can answer some of those things and all learn something from today's presentation. I'd also like to just wish everybody a happy holidays and have everybody just give a special shout out and thought to our service members serving overseas that aren't able to be home with their families. As Scott mentioned, I did serve 25 years in the military, combined between the Marines and the Air Force, and it's definitely something that we should consider during this season. But who we are, the telemedicine network is first and foremost, we're a clinician-based group. We're an independent division of Dignity Health and Common Spirit. So what that means, one of the things that separates us from some of the other services out there, everything that we do is focused from a patient-centered standpoint. That's our largest priority. And we offer these services primarily, as today we're discussing telebehavioral health, but also primarily ICU services, teleneuro and stroke, and many other ambulatory services. But we offer them to our own company, which may seem a little strange to some people, but also to external clients. And that enables us to really provide a patient-based service that we try to standardize across the multitude of companies that we're providing this service to. A little bit about myself that wasn't already explained. My initial exposure to telebehavioral health was as an end user. And I think that's an important aspect of where we've come and how I have kind of taken ownership of the telebehavioral health process and made some of the changes that I have. And primarily, it wasn't necessarily my choice. As many end users, I was an emergency department psychiatric nurse that was performing evaluations and treatment plans and all the things that we know are important for patients. And then one day, we were told that our psychiatry services were going to be provided basically through telemedicine, which none of us had ever heard of before. So again, it was kind of thrust upon us, and it wasn't necessarily something that we chose. And there wasn't a lot of standards. There was really no rule book. There was no plan. So from that struggle and from adopting that technology, and it started with InTouch. So again, one of the things that really made it work was the fact that the technology was effective and the technology worked. So we didn't have the struggles that I often hear when talking with some of the other people out there using telemedicine, where their primary struggle was how to get connectivity, how to get access, how to integrate with the EHR, those sorts of things. We had a steady platform, so that was a good thing. But there were really no rules. It kind of felt like the Wild West, and there really wasn't a lot of guidance. So teaming up with organizations like the American Telemedicine Association provided some of that framework that enabled us to establish some set rules, at least in the beginning as an end user. After using it for, I'd say, approximately a year, and becoming the interim director of an inpatient unit where now my staff were using it, and I expected them to follow that platform and those set of guidelines that we had built, there was an opportunity for me to potentially take the telebehavioral health experience that I had as an end user and spread that across multiple Dignity Health facilities and really try to implement what we felt we were developing as a clinical practice guideline for the use and the development of telebehavioral health, the appropriateness, the timing, the communication, all of those things, and to spread that over multiple facilities. So that's where my experience with telebehavioral health started. And now we are able to utilize that service across many facilities. So here's our mission and vision. And I think, again, just from a business standpoint, it's important to have these concepts as part of our organization. Our mission within the network to provide timely access to quality care from anywhere. And that is two-sided. That is the patient anywhere, the provider anywhere. There's a lot of opportunities. Telemedicine in general is only restricted by our imagination. I think that's hard for some people because not everybody has that drive and that passion to really grow such a service. But with a vision like ours, it says, one day, remote care and in-person care shall be indistinguishable. Certain aspects of this are true today, and we also have certain limitations that are externally imposed upon us. But one day, we truly feel that this is a reality that is highly possible. This again is part of our division, part of our business value and our framework. Just like having patient-centered care, we feel that we, as an independent division within Dignity Health, are centrally located between all of the different aspects, and we want to make sure that our partners, our customers, the hospital-based systems, the provider groups that are providing the service directly to the patients, the vendors that we use, whether it's technology, whether all of those different things, that we have a good solid understanding of the potential so that we can help everybody grow. For example, you wouldn't necessarily think that a telemedicine organization, that part of our responsibility would be to do anything other than provide the providers that are going to see those patients. The reality is we're helping with legislation, we're helping billing, we're partnering with everybody that could potentially be involved to ensure that not only do we understand the limitations, but that we are operating and working at our highest scope of practice, enabling all of our partners to work at their highest scope, and ensuring that as decisions that are external to us are being made, that we have as much influence as possible so that we know we can really drive high quality and make sure that things are going in a direction that makes sense directly for the patients. So here's what I've created as far as my internal arm of the DHTN, the Dignity Health Telemedicine Network. This is what I think our mission is. many would think it's, getting to the patients and making sure that the hospitals have access. But the reality is the overarching mission for me is creating behavioral health parity and equity that is on par with traditional medicine. And much of my focus, again, as a psychiatric nurse, as working in the emergency department, in outpatient centers, in locked in patient units, both as a floor nurse, as a supervisor, as an interim director, seeing the disparities is what drove me to becoming a psychiatric nurse. The fact that we don't treat our patients, or the system doesn't treat our patients on par with traditional medicine, is so disheartening. Many people give up. I chose to lean in and really try to drive modern medicine to create that behavioral health parity and equity. Telemedicine itself is designed to grant access to specialists. All of these things are the underlining vision and structure behind what we're doing. So if I ever have to ask myself, if somebody proposes an opportunity or a challenge or some sort of new thing, often in technology, people tend to focus on shiny new objects. I try to look at this list and say, what are we doing? We're providing access to specialists. We're increasing that access. We're standardizing outcome measures. We are developing clinical practice guidelines that enable us to develop a standard that makes sense, that we can actually measure. Reimbursement. I'm on the American Telemedicine Association, one of their special interest groups for reimbursement, simply because we know that this has the potential to really grow the interest in providing high quality service. And without the reimbursement, without it having some sort of parity and equity, any arm of medicine has the potential to get off track. So we want to make sure that providers are maintained whole, that the patients are able to get service, and that we're paying attention to the reimbursement as we make decisions. And then again, the overall thing that we always hear with patients is the stigma of being a behavioral health patient or receiving treatment. What a lot of people don't understand or don't recognize is that our providers of these services, psychiatrists, psychologists, therapists, psychiatric nurses, social workers, they also have kind of the stigma that's overlaid. So we want to address that. And again, part of what you'll hear today is not just about telemedicine, but about addressing the behavioral health needs and really redesigning the behavioral health system, kind of like a healthcare 3.0 that incorporates telemedicine as an increased access. So the current scope of services for the Dignity Health Telemedicine Network, again, we're offering emergent, scheduled, acute, and subacute services, ideally across the entire continuum. Currently, we offer services in California, Nevada, and Hawaii. And it's, again, just a reminder, it's both dignity and non-dignity customers. We're at 25 hospitals for telebehavioral health, and one of the great aspects of this job that I didn't anticipate was the opportunity to work with 14 plus different counties throughout the state of California. For those that are in the industry of behavioral health, we know that California is unique in the way we manage our rules, as we may say. So we have one standing overarching guideline for the management of behavioral health clients. However, each individual county has the opportunity to interpret those rules the way they see fit and implement them the way that best suits their needs. This creates quite a lot of challenges, especially for some of the rural areas or counties that may not even have an inpatient behavioral health unit. And if your county, for example, does not allow you to quote unquote ship patients outside of your county, yet you don't have the resources within the county, that creates increased length of stay for the emergency departments and really just creates challenges that are virtually impossible to manage. So again, access to providers, being able to appropriately identify the right patients that would need that highest level acute inpatient stay. We'll talk about that a little bit more later. Being able to identify those patients, parse out the patients that you can manage in the emergency department, and then provide them the appropriate care, provide high quality disposition. This does nothing but increase the ability to really provide high quality care to those patients, and also increases satisfaction for staff that's providing the care. Nobody goes into healthcare to provide bad care. That's not what we want. But because it's not something that emergency departments are really designed to do, being able to provide high quality care is a challenge. But what we see is when we have really high outcome effectiveness measures and we hold ourselves accountable and we provide access and we do the right thing at the right time for the right reason, we really can make really great opportunities for our patients. And all of the metrics, when we do the right thing, we see all of the metrics go in the right direction. And that's, again, we'll talk a lot about data, and I welcome all of your questions about data. I was not a data person before I got into this industry, but going into higher healthcare education and really looking at data and developing effectiveness measures for programming, I'm now in love with data. So that's become a huge aspect of what we do. Again, we're seeing about 1,000 to 1,200 consults a month, and we're in emergency departments, acute care units for med-surg and consult liaison services. We also have 2 ambulatory clinics that we're running and that are seeing great success. We have some skilled nursing facilities, and then every once in a while we'll dig into the inpatient psych facilities to offer some coverage there as needed. Now, this is something that we kind of fell into. Obviously, as a turnkey operation, we're offering the people, the process, and the platform to ensure that if somebody chooses the Dignity Health Telemedicine Network as their choice for services, we can bring all of those things. One of those things, 2, we also offer some consulting services to ensure that people, make some wise choices in their technology as well as their customer base, those sorts of things. But really, as a nurse, I saw this as an opportunity, and it kind of came as an epiphany for me. But for me, this is the telemedicine 5 rights. Just like we have the patient's 5 rights as far as giving medications and identification and those sorts of things. For me, this is a logical platform to consider when making some choices. So using the right provider in the right location at the right time for the right reason, using the right technology. If these things make sense to me, it's almost like a recipe that you can just refer to and consider. And of course, in modern healthcare, we also want to use the quadruple aim as our background. So for us, it's really not just a slogan. All of our data metrics, all of our contract goals, all have a space within this continuum. We want to make sure that we're accounting for staff experience as well as patient experience. We want to be able to measure health outcomes, not just our own internal metrics, because that's really not what we're here for. We're here to make sure that the patients are receiving high quality care and that their outcomes are improving, that our customer, which truly is the hospital, that our customers' identified goals are improving. And the majority of the time, because of the business, that turns into lower costs of care. But if we're doing something that is increasing the cost of care or lessening health outcomes, we want to be aware of that. We want to make sure that these are parts of our consideration. And obviously, if the opportunity to hit all 4 is very rare, but if we can hit 3 out of 4 in a decision that we make, we want to make sure that we're making those considerations. So let's get into the purpose of each of the 2. I'm going to split this into emergency department and ambulatory. The consult liaison kind of folds into the emergency department because ultimately it's either an acute or a subacute need. The only difference there for us is It's not about quality, but it's about the timing. So if a patient, for example, in the inpatient unit wants to wait until their family is able to be present, or if they can kind of make some disposition decisions before seeing the psychiatrist, we want to account for that. But in the emergency department, which is about roughly, I'd say 90% of our total business, here's our purpose. We want to increase access to specialty services for the patient and also for the staff. What we see is that providers, again, emergency physicians, great. We work with some of the most amazing emergency department physicians, and we want to offer a service to them that is peer support, so that if they have internal process improvement plans, such as use timeliness of medication, the appropriate use of medication so we're not over sedating patients, safety, things like that, we want to help support their decision making so that ultimately they can actually use us less. We don't need to see every patient in an emergency department. We don't even need to see every behavioral health patient. What we want to do is we want to be available to see the right patient at the right time, as we mentioned earlier. So timely, appropriate assessments, making sure that we can provide recommendations for medications. We can help hospitals determine the level of safety and observation that's needed for each patient. With new Joint Commission standards, a lot of hospitals are struggling to determine what patients need sitters, what patients don't need sitters, and how that all works, especially when it comes to the cost and utilizing appropriate resources. We have found success in helping identify those things, and of course, disposition, the involuntary holds, things like capacity determination, we've also done some assistance with. And so moving on, reduction in length of stay is usually what the hospitals, their first ask is. We want to determine what our length of stay is, and we want to reduce that length of stay. It's very challenging, as we all know, with this population, especially because it's hard for people to realize that this is one of the only healthcare programs where we're almost solely relying on external resources and external support. We've got county mental health departments that are either seeing our patients or making determinations that we, as the primary healthcare provider, are not authorized to discharge a patient, even if we feel that it's the right thing to do. That's a struggle that the industry is always going to have to deal with, at least for now in the current landscape. But reduction of length of stay, for me, it's a great thing to track, and it definitely relates to the finances, but only if it's the outcomes for the patient's quality equal the reduction in the length of stay. I don't like driving down that number simply because we can allocate it to dollars. I like to also combine that with the safety, the recidivism, being able to track 30-day recidivism with our new reimbursement landscape. What are the outcomes for that patient? Do we follow up with our patients? I know some of our emergency departments have started putting in follow-up phone calls. There's so many cool things that we can do. Regulatory standards, EMTALA, CMS, Joint Commission, even patients' rights. I always encourage customers, again, hospitals, to engage with the county, make sure that everybody is on board, that everybody is aware of what we're doing, and that we're all working at our highest scope. And again, working across 14 counties in California, we're able to have those conversations and really try to stretch the tolerance of what people will allow us to do, and then back it up with data, and then use those as potential clinical practice guidelines, best practice, publishing and putting all those into evidence-based practice, and then spreading the word, disseminating what we have found through our implementations, and trying to ensure that we are elevating everybody. And if one county or one patients' rights organization is willing to stretch and take some risk, then we want to lean in those areas, track the information critically, and report back and see if anybody else is willing to go along for that ride. Because telemedicine, part of it is about having that innovation spirit and stretching and pushing where possible, but safely and responsibly, and ensuring that, again, we're doing all of these things with the patient at the center of this conversation, but also understanding that the hospital is our customer, and we want to make sure that everybody's needs are met. So a reduction in inappropriate costs, things like sitters. This is what we constantly hear, that, for example, our hospital assigns everybody as a one-to-one. Things like that, we want to make sure that the decisions are being made not in a vacuum, but we want to help with those decisions. And again, because we are working with so many different organizations, we have kind of a visibility of what's working and what's not. So we can prevent people sometimes from making some poor choices, and just being aware of what's possible. Improving patient outcomes and satisfaction, improving overall safety, and again, staff satisfaction. We know in interventional science that there's going to be some early adopters, there's going to be some people that are just absolutely never going to get on board. But when we hit that tipping point, when we can ensure that the people that are actually treating the patients on the front line, because let's be realistic, from a telemedicine perspective, we're remote. So we're in and out. We have very little control about what happens to our patient before we become part of that picture. We don't even know that they exist. It's kind of like this magical process. They're there, then we get called in. We're expected sometimes to work miracles, but we have no control over what happens before we see the patient, and we rarely have full control over what the actual outcomes are. We can make recommendations, we can participate as much as we're allowed to, depending on the environment. But when we ensure that the staff is satisfied with the process, it's not always going to be perfect. We're not always going to agree 100%. But when we're satisfied, when the staff is satisfied overall, then we get that buy-in and that enrollment in the overall process to ensure that we're moving forward. And when things are not working correctly, that the staff is likely to let us know so that we can identify those concerns, and have really, really crucial conversations around making sure that we assess. So moving on to our ambulatory clinic, again, we have 2 ambulatory clinics in remote rural areas in California, and they're designed to increase access to specialty care, to include addiction and medication-assisted treatment. We want to make sure that we are addressing the current issues as well as the tried and true needs. This kind of shifts our psychiatrists a little bit. One of my largest recommendations for an ambulatory clinic is provider choice. We have definitely experienced some challenges over the years with putting providers in that position that maybe it wasn't their specialty, but they had a willingness and we had a need. I would always recommend that you focus on having high quality providers and specific expectations. This is an amazing avenue for telemedicine that could change the landscape instantly if utilized appropriately. But it is a lot of work for the providers, and it's a challenge sometimes to maintain that relationship remotely, but hugely important. One of the things that we discuss with customers when they ask us to come in and manage the emergency department, that's the crisis that they see in front of them every day. I've got 7, I've got 14, I've got 18 patients that we're boarding, that we're holding, that we don't know what to do with. We can't send them home. All of these things are going on. And I always ask them, are you willing to also add ambulatory services within your network? Because if you are focusing, and this is one of the lessons that we'll talk about, but if you're focusing solely on the crisis that is directly in front of you, and not addressing how that crisis started or the long-term solution for this emergency department crisis, you're really spending your finances, your time, and your effort in potentially the wrong place. Granted, we have to build a service that is going to put out the fire that is directly in front of you. But the reality is the best way is through prevention. And what I kind of try to tell facilities is you're trying to put out that fire every day. With limited resources, I would recommend that you build a firehouse just down the street so that you have a way to have patients go somewhere else before coming to you, and you're also building kind of an outlet valve for your emergency department, because what we have seen over time is a good majority of the patients can be discharged if they have a plan, if they have outpatient resources, if there's so many ifs, but the reality is those ifs are unlikely to build themselves. So when we parse out all the money and we put all the chips on the table, if we can slowly shift them from the crisis management to the ambulatory clinic, I feel that, again, we increase that satisfaction and we provide a new landscape, behavioral health 3.0, that these patients can have options that they didn't before. And I think it's highly beneficial. So again, reducing the need for crisis intervention by having a place for the patients to go, providing options, and again, improving overall population health. Part of this we'll talk about with the overall lessons learned. So here is my sepsis versus behavioral health. I love sepsis, not because it's sepsis, but because there's been so much focus on sepsis lately. And I always try to relate the behavioral health emergency to the sepsis emergency. I say that psych should be the fourth S. I know it doesn't start with an S, but we have sepsis, STEMI, and stroke, that we have all of these clinical practice guidelines. We have expectations that if we don't follow, we kind of get in trouble, and we know that doing the right thing for those patients is always, is more likely to work than not. But in the behavioral health world, we keep I say we as the behavioral health specialists, we often keep this as a very squishy science. Sometimes we like to just assume that there's nothing we can do. All the patients are so different. There's so many different shades of gray that these patients fall into. If only, right? If only there was an algorithm. If only there was a proposed management system, then we could attempt to manage these patients. I propose that there is. There's enough evidence out there from the Emergency Nurses Association, from the American Association of Emergency Psychiatry. There are guidelines. There are success measures. There are ways that we can manage these patients on par with sepsis, that we could say we are doing the right thing in the right order at the right time, and our outcomes are demonstrating that, for example, when we use the patient's own home medications, patient comes into the emergency department, we use their medications instead of overly sedating because the patient may be aggravated, yelling, we don't focus on de-escalation enough, all of those things. And again, this is before they even see a telebehavioral health provider. We are increasing access to telebehavioral health providers, but if we're not there for the right patient at the right time, it's not going to have the positive impact that we want. So if we have a sepsis patient, we determine through the algorithm that they meet sepsis criteria, we kind of have an intent to admit, right? This person is going to go to the ICU. Well, if our ICU is full, then we hold them in the emergency department. Well, we know what treatment, or we ask an intensivist or a specialist or somebody, what are we going to do for this patient? Just like a consulting telepsychiatrist, they give recommendations, we put those recommendations into place, and then we monitor for the success of those interventions. Well, if the sepsis or potential sepsis patient improves and doesn't need that higher level of care, the ICU, we divert. Maybe we send them to the med-surg unit, we figure out where they can go. But we're still boarding that sepsis patient. If we overlay the behavioral health treatment plan for the emergency department, we can do the exact same thing, and we can either divert from that ICU level inpatient involuntary locked unit, we can either divert from there, or we can potentially, for our behavioral health patients, identify the ones that can go home. And that's really what we're trying to do with the Dignity Health Telemedicine Network, is we're trying to improve or build recommendations and build clinical practice guidelines for the section of time before we intervene, and then make sure that when we intervene, we have enough information to provide high quality service for that patient so that we can identify, is this patient appropriate for diverting from their current plan? Or do we need to come in and do we need to divert them and say, you know what, this is an ICU level behavioral health patient. It may not come across that way. It may not seem that way. And it may be really tempting to send this person home because obviously that's going to immediately end your length of stay. But we want to make sure that the right patients are going to the right level of care. If we, as a health system, sent every patient that came in with a fever, and we use that as the sole identifier of sepsis, just all by itself, you have one piece of information, and we said, this patient is septic, they're going to go to the ICU. All of our ICUs would be full every single day, just like we use things like one piece of information for behavioral health, potentially the verbal acknowledgement of being suicidal. If a patient says, I'm suicidal, and we said, okay, well, that's that one piece of information. We're now going to send you to our ICU for behavioral health. And guess what? Every single bed in the state of California is full at midnight every single night. So we have kind of created that situation unintentionally, I feel, and we tend to say, you know, we need more beds, we need more ICUs for these patients to go to. My personal perception and my take is that we really need a better management system to identify who needs that ICU level care and how we can potentially divert patients by offering other resources and making sure that only the patients that absolutely need to go to that involuntary level of care, they're the ones that get accepted. When we partner and we have that that full continuum of care, when the DHTN partners with external resources prior to the emergency department, like county mental health, like ambulatory clinics, like PCPs that are out in the community. When we do that and we partner with the emergency department, where ultimately we can't control, right? We're going to see those patients, according to EMTALA, those patients show up, we're going to provide them the best level of care that we can. When we participate in the emergency department as that safety net, and we partner with the inpatient facilities to ensure that if the DHTN confirms and sends you a patient, that they have been seen, your reimbursement is likely to be, you're likely to have a higher chance of getting reimbursed for those patients because we are providing physician certified medical necessity for those patients. They're going, and if we can start treatment early in the emergency department, that's crucial. We're making medication recommendations. We're ensuring that they have the right level of observation and safety so that we're not degrading their mental health while they're in the emergency department. So we're providing treatment early. One of our kind of down the road goals is to be able to track the patients that we see in the emergency department and what their length of stay is. Because if we feel that if you provide the right medications early and the right level of observation, as they get to the inpatient unit, those length of stays and the ability for the inpatient unit to appropriately get reimbursed for the services they're providing and ensure that they don't have extended length of stays is going to ultimately benefit everybody, because we cannot control those external beds. But what we can do is ensure that only the correct patients are going and that those external inpatient beds have the ability to turn over those patients appropriately so that they can create new bed availability. So that's the sepsis versus behavioral health model. We're going to get into the lessons learned, and then we'll have some time for questions. But telemedicine alone is not going to fix it. Whatever the issue is, it's unlikely that just adding telemedicine is going to fix it. What telemedicine does is it improves access to providers. Telemedicine alone is not going to reduce the stigma of the staff or the patients. It's not going to alone train staff to make the right decisions for treating the patients. Communication is key. Telemedicine is a remote provider. We don't know maybe some of the nuances or the things that are going on. It's not going to just automatically make everybody talk and have great communication internally. It's not going to fix the workflow. It's not going to help de-escalate the patients just by itself. And it's not going to have improve the relationships or the policies that you're faced with from external governmental agencies like county mental health departments and things like that. What it does is it will improve access to the providers and allow for new conversations. We are elevating the conversation, and it's so amazing. I always kind of lay this out when we talk with customers and say, you'll know when it's starting to have that desired impact, because staff will go from a sense of hopelessness around not knowing what to do with these patients and just being so dissatisfied. The conversations will get more challenging, but they start to focus around evaluations, medications, and offering high quality treatment to the patients rather than that sense of hopelessness. So here's some of our data. As we say in our office, the data will set you free one way or another. But my recommendations are to set realistic goals that are measurable. Everybody's heard of SMART goals. We want to make sure that these goals are measurable, that they're attainable, and they're holding everybody accountable, including yourself. It's hard sometimes because when we set high quality goals that are lofty, sometimes we have to hold ourselves accountable. I always recommend not settling for anecdotal perceptions when we have data. And that's, again, an additional benefit of having the data, is because we hear a lot of anecdotal perceptions. And then when we put it face to face with data, then we can get into the conversation. And again, intervention science says you define your success early and then be able to continually measure those benchmarks. And this goes good for patient quality as well as for contracting. So here's what we focus on. Our service measure and goals we try to see the patient within 60 minutes of being requested. Ultimately, our goal is 37 minutes. Right now, we're running at about 47 minutes, and that fluxes, right? It goes back and forth. Note sign time, which is kind of the end of our intervention, from the time we're activated until we're done, 90 minutes. Our goal is 60. Right now, we're at 87. Very transparent. We're right at the edge. And then our disposition goal. Nationally, what we see in talking with people, we work very closely with organizations like the California Hospital Association, and trying to achieve that magic 70-30 split that kind of a lot of research is out there as far as discharging patients from the emergency department. I personally feel, having worked inpatient, a good majority of the patients that arrive to the inpatient unit don't need my level of ICU intervention for behavioral health, but they come to us because hospitals maybe don't have any alternatives. They don't know what to do with the patient, so they end up getting to that level. I feel that probably 70% of the patients that are in the emergency department or that end up in inpatient psych don't need to be there. That doesn't mean that they could just be discharged willy-nilly with no plan, no follow-up, but they don't need that ICU level care. So we have some specific limitations with telemedicine. So my goal for telemedicine is to hit that 50-50 split. If I can have discharge recommendations that are roughly around the 50% mark, that's where I'd like to be. Our large aggregate data right now puts us at about 73% transfer and about 27% discharge, but there's a caveat to that. We actually admit patients to inpatient psychiatric units through telemedicine in certain counties in California. So what that does is that skews our overall aggregate data. And when we look at facilities that we don't admit to, we're actually able to get much closer to that 50-50 split. And I'll show you some of our actual data. again, data has
Thanks,
proven.
Sean. I also wanted to jump in real quick and just let folks know that for some of this data, they can check out our handout section on their audience console. We have a case study that we did with Dignity Health's telemedicine program on behavioral health, and that has a little more context to some of this data that I recommend everyone checking out that's on this call. And also wanted to remind folks that since we're getting close to the end of the hour, to go ahead and put in their questions now, and we'll try to get to all of them that we can in this hour, but if not, we'll follow up later via email.
Yeah, thanks, Scott. Thanks for that reminder. We spent a bit of time on that case study, and I would encourage everybody to just check it out. There's some great information. A lot of it is repeated again from what we're talking about today, but the data, I just can't stress how crucial this is, because again, it validates what you're doing, and the numbers don't lie. So here we are again. We're also tracking things like multiple antipsychotics. It's an HBIPS requirement for inpatient psychiatry, but there aren't a lot of emergency departments that are able to really determine how many of their patients either need or received multiple antipsychotics, and the impact that multiple antipsychotics directly has on your length of stay. So we chose to track our psychiatrist recommendations for multiple antipsychotics, and our live action data in this dashboard actually enables us to use the multiple antipsychotics as a filter to determine some of our data. One of the things that I want to stress is my internal proposal for behavioral health management includes trying to manage as much of the behavioral health process in the ED within the first 4 hours that patient is present. As you can see from this highlighted arrow, this is the average activation time for this select group of facilities. So this would indicate that those facilities are waiting 23 hours and 43 minutes before asking for the telepsychiatrist to assist with these cases. Again, the number in and of itself doesn't tell us exactly why this is happening, but it does give us a conversation point to say, can we improve this? Should we improve this? And what's the impact if we reduce this average activation time to say 4 hours? Would that directly correlate to reducing your length of stay by the equal number of hours? And again, without having that data point, it's hard to know where to start. So this is our, again, another sample piece of data, the same facilities over the same period of time, but our discharge rate, again, our transfer rate here is about 58%. So we're getting closer to those numbers. And through our personal documentation system, which was provided by InTouch, we're using again, InTouch's technology as well as the clinical apps EHR. We're able to parse out this type of data. So we're actually able to determine from our recommendations how many involuntary holds were placed, how many times we had voluntary admission recommendations, how many times we maintained a pre-existing hold. So if you have a law enforcement agency that continues to bring in patients, they're all on a hold, and a psychiatrist has seen that patient and determined that the hold was valid and maintained, we can provide that data, and it's hugely impactful when we have those external client conversations. And we're also able to determine how many patients we were able to recommend were released from those holds. Again, this is data that's so impactful, but it's hard to really put your thumb on. So this is just a quick snapshot. Again, same data, same facility, same period of time, but it shows you when these patients are coming into the facility. It actually shows when we are being activated. So we would expect that if somebody had a psychiatrist or a nurse practitioner or somebody seeing these patients in the emergency department, maybe during business hours, we wouldn't see this volume. But this is when these facilities are using our service. So again, it helps for us with staffing. It helps the hospitals to really focus on what's actually happening with those patients. So again, finally, telemedicine is hard work. There's no question about it. It's hard for providers, it's hard for staff, it's hard for hospital leadership. It's hard. It's not less work. And a lot of people feel that telemedicine is the silver bullet, it's gonna solve all our problems. Really, it's not less work, but it is better work. And we're providing the right level of care for these patients and making sure that we're doing absolutely everything that we can. And I can't stress enough, the technology that's used, it has to become invisible. If you're relying on a remote provider to be able to beam in and see a patient and the system isn't working, it's only going to create more havoc, more problems. So again, so thanks to InTouch for making sure that the technology has been reliable, that it's supported, and that we're able to do our job, which is patient care. I'm not a tech guy, so I don't want to be trying to focus on the widgets and the zeros and ones. I want to be able to focus on quality patient care, workflow, having those great conversations and making sure that we're accomplishing all of our goals. So where will the future take us? This is actual patient data here. So this word cloud that was created by our data analyst, this is real-time data from what our providers are documenting within the InTouch clinical app system. And you can see the number one, it just happened to be the number one center of this, and the most used word is patient, not surprising. But where are we going? You know, really ambulatory care, I think, is one of our primary focuses. Utilizing e-consults, which is peer support for the primary care providers, things like direct to consumer, maybe going into the home, making sure that follow-up care, either pre-hospital or post-disposition is able. And again, indistinguishable care, full EHR integration is an ultimate goal. Patient management, treatment teams providing advanced practice providers, nurse practitioners, psychiatric PAs, social workers, nurses, all through telemedicine is all possible. We're only limited, again, by our imagination. And then being able to use this data to predict the hospital's needs, the patient's needs, providers' needs, all of these things, being able to use predictive analysis to say, if we did this year, with all the data that we have, can we ensure that the same thing is replicatable either in another facility or at the same facility in a future state? So that's what I have. Again, we welcome all of your questions. I hope that we've spurred some questions, and I'm going to pass it back over to Scott to kind of negotiate some of that.
Thanks, John. Yeah, so we do have a few minutes for some questions, so I'll just get down to it. I also would like to remind everyone that if we aren't able to get to your questions, we will answer them later offline. So first, our question is, what are the guidelines as far as having a licensed professional, either LPN or RN? In the room for a emergency medical visit.
Yeah, and again, this is one of the benefits of developing a really good relationship with organizations like the American Telemedicine Association. It varies by state. So they have, certain states have mandates for having a telemedicine assistant or somebody that's there to be directly with the patient. What I recommend, so the state of California does not have that mandate, which is kind of a double-edged sword. When we mandate that somebody is there, we get higher participation from bedside staff. Obviously, it's mandated. They're there to participate, but sometimes it's not appropriate. And we want to be able to protect privacy and ensure that our patients are getting the right level of care. I always recommend that that staff participate as much or as little is as appropriate for each individual case. Unfortunately, our behavioral health clients aren't always fully honest, and they're not always willing to give all the information to anybody, let alone a remote provider. So I do encourage that staff participate as appropriate. California does not have a mandate for somebody to be at the bedside for behavioral health. But again, some of the other telemedicine services may be different, stroke, for example. So I just encourage people to be aware of the rules and the regulations within their state, and then try out different things and see what works best for them.
Great, thank you. So the next one says, an issue that repeatedly comes up is even with telepsychiatry in an ER setting, ER physicians are very reluctant to take recommendations from teleproviders, partly for liability, but partly for other factors, and if you had any thoughts there.
Yeah, and I'd say you're right on the money. Communication is key, relationships are key. Our providers are all on the medical staff at the facilities where we operate, and we, as my providers often tell me, they get the same group of all of the same emails that every provider at that hospital gets. The only difference is they get them from 25 different facilities. So having our providers be on staff and kind of being as much of a partner as possible is where I think we find those successes. And then education, providing not just the telebehavioral health education, but the behavioral health education, and partnering with community services and shoring up the relationship and allowing those providers to ask questions and to work at their highest scope possible, and then working with the internal leadership for those facilities to make sure that we're all in alignment, right? The providers aren't going rogue. Our providers aren't making recommendations that are just ridiculous, but that we're all partnering together for the best thing for the patient, and then tracking the data so that we can make sure that we have accountability and we have the ability to communicate back and forth. But yes, that's absolutely, we see that, and it's just something that we work through over time.
Sounds good, thank you. So this next one is asking about the challenges that you see in the delivery of experience and operations for telebehavioral health.
I'll take a stab at it. That's a tough question. Delivery of operations. I would say that partnering with experienced teams that have established workflows and established processes for both implementation as well as ongoing care and provisions of care is extremely important. Also, one of the major challenges is the fact that, again, behavioral health in the emergency department does not have a standard. There is no established clinical practice guidelines. And so when you compare it to things like stroke, where many hospitals will have if they have a tele-stroke program, they'll have a tele-stroke coordinator, and they're responsible. That's their job. They're responsible for managing the success of that program as well as all the metrics. What we don't see in any of our facilities, which is unfortunate, is a telebehavioral health emergency department provider or a clinician that's responsible for that, and that's their job. It's even if it's a combined position, that would be great, but operationally it's different. And if we put the resources into behavioral health the way we did to areas that are mandated by CMS, Joint Commission, we would likely see improvements just like we have with sepsis, STEMI, and stroke. I just think we need to create that on par with traditional medicine.
Excellent. So I think we have time for one more here. So briefly, I was wondering if you could walk us through what some of the onboarding looks like for providers, both remotely and on site, especially since some of them were outside of Dignity Health's network.
Yeah, so we have a standard process. All of our providers are licensed in the state where the patient is receiving care. They're all fully credentialed at the facilities. So we partner with a provider service organization as mandated by the rules in the state of California. That's where we're based. And then we authorize our provider service organization to recruit providers. They present them to us. We go through a screening process, and we meet with the providers. We make sure that it's a good fit, and then we kind of authorize the credentialing process. And then we team with them ongoing to make sure that everything is going well with the facilities. And then we do ongoing weekly meetings with our provider groups for quality metrics and making sure that everything's going on board.
Great, thank you. So that gets us to the end of the hour. So I'd like to give a big thank you to our presenter, John, for today's webinar. Also, for additional questions or information, you can please contact us at the email address on the screen, feedback@intouchhealth.com. And then I also encourage you to please visit our website to find a recording of this webinar, as well as a list of past webinars in our series to check out. So thank you everybody for joining us and have a good rest of your day.